Thank you very much for this invitation, and we'll indeed start by introducing consciousness and disorders of consciousness, where in the absence of a generally accepted definition, as physicians, of course, we need to make decisions. So how do we do that? What if we need to quantify consciousness at the bedside in patients? So let us start by the most difficult patient, and that's a philosopher. We'll take Ned Block again. If we want to say meaningful things about Ned's consciousness, how we will do this is to reduce this complexity of consciousness to two dimensions. First, we'll check with the different Coma scales. Glasgow Coma is the most used, to his level of wakefulness.
Arousal, which is quite straightforward. We'll just check if Professor Block has the eyes wide open. If not, we will stimulate him, even apply nocture stimulation, so to make sure he is fully awake, because that is necessary, but as we'll see, not sufficient for him to be aware of himself and of the environment. And that is what we experience every night, this relationship between wakefulness, arousal, and awareness of self, our environment, when we fall asleep. When you fall asleep, you at one point lose awareness of your environment. Already we see that there's an exception, a notorious one, during REM sleep. Lucid dreaming is even a very extreme example of one becoming aware of your oniric activity, of your dreaming state, while from the outside looking asleep. And the patients in coma, by definition, cannot be awakened, meaning they will never open the eyes, even if stimulated. The same holds for general anesthesia, where anesthesiologists, and we'll hear much about that tomorrow, have different drugs to reduce the level of wakefulness so that the patient will lose awareness of the environment and the surgeon can do his job. Now, coma will not last for long periods of time. After a couple of days or weeks, some patients might awaken, meaning open the eyes, yet only show reflex behavior. That was defined in the 70s as persistent vegetative state. It's an unresponsive wakefulness, meaning that the patient is awake, passes the wakefulness test, eyes open, yet he fails to pass the awareness test. And what is that? That is, first of all, looking for non-reflex behavior. That's not so easy. Huh? You just moved. Was that a reflex? Was that voluntary? There's a lot of discussion about what is truly a voluntary action. So our most convincing awareness test is looking for response to command. So if we take our patient Ned again, we will ask him to raise the left arm. You see, philosophers always a problem. Nobody saw it. But he made a movement with his left arm, and that will be taken as proof of Ned's being conscious. Already you see that this can be problematic. Maybe he's conscious and yet fails to move, because he can be deaf, so we'll write it down. Or because, and that can happen in some patients, he has lost his voluntary control of his muscles after a traumatic brain injury. There can be lesions in the nerves, spinal cord, brainstem, and then we really have a problem. So it's important to emphasize that our quantification of consciousness at the bedside is or can be biased by the fact that we are actually making inferences based on motor behavior. And this is why I think it's so exciting now to see we have these functional imaging and electrophysiological tools to go and measure what's happening in the brain. There are some other examples in neurology where we can have this dissociation of reflex motor activity in the absence of response to command, like epilepsy, absence seizures, complex partial seizures, where also patients can have some automatic motor activity, just as in sleepwalking, but if you would ask them to do something, they would not respond. And I think these cases are very interesting for us to understand the so-called neural correlates of awareness. Some patients
who are after coma, evolving to vegetative, unresponsive wakefulness, can remain in that condition for years. Others can show some minimal signs of consciousness, such as following with the eyes when you would go from left to right in the room, or smiling to their mother, and only if it's the mother. You can't say it's a reflex, and this is coined minimally conscious state minus. So there's evidence of non-reflex behavior. And minimally conscious state plus is as soon as the patient shows response to a simple command, but not in a way where you can use that response to establish a yes-no communication. You can't say, squeeze my hand twice to say yes, once for no. This will not work. So it's a very frustrating situation where you know where sometimes there's evidence of awareness, but it's fluctuating in time and you can't communicate. And as David already pointed out, this is very important. When you want to share your conscious experience, well, that needs communication, verbal or non-verbal communication, which is impossible in this condition called minimally conscious state, only defined in 2002. So really, medicine is struggling how to deal with these patients. And then finally, there's patients who can awaken from their coma fully conscious, yet unable to move. Their legs, their arms, they can't speak, and this is coined locked-in syndrome, classically caused by a lesion in the brainstem. So it's
an intact brain where all the motor fibers are damaged. Classically, it's a vascular lesion after a stroke, touching all the motor fibers and the cranial nerve nuclei responsible for speech. So it's a form of pseudo-coma.
It's not a disorder of consciousness, but it can be mistaken for one. As you see, these two dimensions of consciousness, wakefulness and awareness, are not black or white, all or nothing phenomena. We should see them as a more graded, gradual entity. And I think, as said, that functional neuroimaging now offers us a tool to try and measure
what is needed for us to be conscious. And this slide shows us results from positive emission tomography, where you can basically quantify the metabolic activity of the brain. So you inject radioactively labeled glucose.
It goes into the nerve cells. These cells are the ones using the most of energy of any other cell of your body, and 100% fully awake and aware brain. And the question we would ask here is, would there be some kind of threshold? If overall activity in your cortex would go down, you would simply lose consciousness. And definitely, this is the case in brain death. This is the so-called empty skull sign, where you only see activity in the skin surrounding the skull, none in any of these billions of neurons. Irreversible
coma, brain death. Tonight, when you fall asleep in deep, slow wave sleep, you see overall activity of the brain going down to levels around 60% of normal waking values. And in rapid eye movement sleep or paradoxical sleep, something paradoxical
happens, where you have these dreams occurring. Overall brain activity is very close to normal waking. In general anesthesia, again, you see
this relationship when anesthesiologists, and we will hear about that more tomorrow by Harry Schein, give basically any drug that makes you
unconscious, no response to command. Your overall activity will massively decrease around half of normal values when anesthesiologists stop
the drug. Consciousness returns, and so does overall brain activity. So far, so good. Seems to be this correlation between overall activity in the brain and absence or presence of consciousness. Now, that relationship is not so straightforward in pathological loss of consciousness. Both coma, vegetative state, you see this massive global reduction, about 40% of normal waking values when patients can be in the vegetative state, awake and unaware. And some of those patients will recover, and we had the opportunity to rescan them, and you see it's not a recovery of a full 100%.
In other words, you don't need your whole brain to be conscious. There is a critical network. It is, I think, much less than we historically thought. You need only part of the brain to be active for you to be consciously aware. And now, using statistical tools, we can identify this so-called consciousness network. It's not a small region in the brain. It's this
frontoparietal network of both left and right hemispheres. You see there in yellow and red, and this midline front and back network again that is
systematically impaired when patients were studied in a vegetative state, unresponsive wakefulness, and which is also observed when we look at seizures. You see in green data obtained in complex partial seizures using SPECT imaging. You see in blue absent seizures, where patients would just be absent, fail to interact for a couple of seconds, and this is an fMRI study showing decreases in blue, again in this widespread frontoparietal network, and finally in sleepwalking. One patient studied so far only by Claudio Bassetti in Switzerland, injecting again radioactive labeled tracer when the patient in slow wave sleep starts to walk, and you see in yellow now the decreases in this widespread network. So I started by emphasizing that you have this relationship between the two components of consciousness,
the level or arousal
and the content or awareness, and they show this
negative correlation classically observed in sleep.
I would now propose to again reduce the complexity of awareness into its two main components, and that is sensory or perceptual awareness of your environment. It's everything you see and hear and feel, everything coming through your senses, and then so-called awareness of your internal world, which is this little voice talking to yourself, this internal dialogue. You can have this mental imagery or awareness of self if you want, but this is has a lot of other connotations. And there you see this negative correlation. And the take-home message of this introductory talk is that
you have neural correlates for both of these dimensions. We've already seen that there's this global frontoparietal network where we've reason to believe that the lateral areas of both hemispheres,
front and back, are critically important for external or sensory awareness, whereas this midline core in blue is important for internal, or if you wish, self-awareness. And we'll now see a couple of studies illustrating that what is important is the interaction between these networks. One neuron we think cannot be conscious, but the interactions of billions of neurons, this functional connectivity between the gray matter and this deep structure here, the thalamus, seems to be of critical importance. So number of studies, this one done here in the lab in volunteers, put into an MRI machine, no specific task, resting conditions, except that they heard the beep once in a while, and then they needed to say by finger button press whether they were more externally aware or internally aware. And then you see, if you correlate the scores, if the scores were more external, you see these lateral frontoparietal areas, and if there was more internal awareness scores, you see this midline core. And at the behavioral level, you see that both scores tend to anti-correlate. At any given moment, you're more one or the other. And we know that from daily life activity, sometimes you can be so absorbed in your reading a book or something that somebody doing something outside you will ignore it. Or otherwise, your neighbor will make a lot of noise. External awareness will be high and making it difficult for you to focus on your work. And it seems to switch at a frequency of 0.05 hertz on average, which is about every 20 seconds, which is also known from these resting state fMRI studies, these spontaneous fluctuations in the Bolt signal. We have reason to believe reflect these external or internal awareness thoughts. So how does this apply to patients? This is a study, you can't read it, by Aurore Thibault, where she used again positron emission tomography, and as said, in patients who are vegetative, you see this widespread frontoparietal network impairment, decrease of metabolic uptake as compared to controls. In minimally conscious state, you see that it seems to be more lateral awareness network that recovers, and these patients show a recovery of awareness of the environment, but the internal awareness network still seems to be impaired. When they recover communication, locked-in syndrome patients, pseudo-coma, of course, they show no impairment whatsoever of the awareness network, and then this is a correlation with the mostly used consciousness scale, which is the Coma recovery scale, and you see again the higher the score on the scale, the higher the activity in this so-called frontoparietal network. And there's a lot of evidence, and you will hear about it today and tomorrow, that for you to be aware of some external stimulus, you don't, it's not happening in your sensory cortices. You don't hear with your ears or auditory cortex. You need this frontoparietal network. And this is a study by Melanie Bowley, where she used a laser at such a borderline intensity that half of the time you wouldn't even feel it, and then the other half subjects would say, yes, I felt a laser on my hand. If you contrast the fMRI images, what you identify is not primary somatosensory cortex. As said, it's a slave system. It's necessary but not sufficient for sensory awareness. You see this frontoparietal network. Studying internal awareness is a bit more difficult for us. We use a lot the patient's own name or own face. This is increasing it's attentional grabbing, autoreferential stimuli, and this is a study done by colleagues in China, where you see that the patient's reaction to the own name will increase this default mode, midline structure, and even more so when the coma recovery scales are higher in patients after coma. There's different ways how one can modulate these two dimensions of awareness, and in Liège we've been working with an anesthesiologist who introduced hypnosis into the operating room, where one can do some kinds of surgeries like thyroidectomies without general anesthesia, but with the patient staying conscious yet being in this specific condition called hypnosedation, which we compared with a distraction task. And you see here that the scores the subjects give during this different conditions, normal waking, distraction, and hypnosis, of course, it's increase of absorption, it's a dissociated state, and there's a decrease of external thoughts. And the fMRI also shows that the external lateral frontoparietal network still is there in distraction thoughts, but kind of breaks down during hypnosis. So you're kind of disconnected from your environment, external awareness network breaks down, and there's an increase of connectivity in the internal awareness or default mode network. So consciousness does not happen, if you want to say it a bit provocatively, in your primary cortices. This is an old study where we used auditory stimuli. They activate your auditory cortex, of course, but also in coma or vegetative state patients. It's necessary, it's not sufficient for you to be conscious. You need interaction, a communication between the auditory sensory slave systems with this frontoparietal external awareness network. And that is only seen in subjects who are conscious, or as here shown, minimally conscious or minimally responsive. There's now many complicated ways we can analyze these signals, both with neuroimaging and EEG. This is high-density EEG with auditory stimuli being presented, and one can use dynamic causal modeling, which is a way to look again at connectivity, but also at the directionality of the connections. And it seems to be that for you to be conscious of an auditory stimulus, you need this top-down or feedback connection, illustrated here by this red arrow between the primary auditory cortex and the secondary auditory areas here, number 2, and then 3 is this frontal associative area, where you need this top-down kind of recurrent loop only seen in consciousness and not in patients in coma or a vegetative state. And of course, if that is true, it is very helpful to make or to reduce the uncertainty we face when dealing with patients. And that is important because, as said, our clinical consciousness test can be biased by the assessment of motor responsiveness. We try to capture consciousness, but actually all we do is depending on motor responsiveness. And in some patients that can be tricky. This is why there's this strange tennis test, which is basically in fMRI asking a patient to imagine playing tennis. It's the same as what we do clinically. It's move your hand or imagine to move your hand, but we don't look at the hand anymore. We'll look at the activation in the motor cortex. And you see here in healthy controls in yellow that we can capture this increase in bolt activity. This is another question. Imagine to walk from the front of your front door to your sleeping room. It will activate a different set of areas here, parahippocampal areas. And then you see these patients with severe brain damage studied both in Belgium, in Liège, and in the UK, in Cambridge, where you see there's traumatic brain injury, very important, a lot of atrophy. This black is cerebrospinal fluid, so there's hydrocephalus. At some places, there's virtually no gray matter left. And from the outside, some of these patients would fail the awareness test, no response to command, no functional communication. And yet in the fMRI, you see that they can respond to the task, activate the specific areas. And in one patient, this even permitted a functional communication. We could explain to the patient, well, patient was sent to us with the label vegetative. It turned out to be wrong. And in the MRI, we see activation of the motor cortex. We can then say, well, if you want to say yes, do this motor task. And then you can read in the brain, more red. The patient to the first question is answering yes. Next question, blue, no, no, yes, no. And sixth question, no answer anymore. These were simple questions. We knew the answer. Is your name Fred? Is your name Mark? Is your mother's name Maria? And so on and so forth, to validate the technique. Of course, it's not practically useful, because as soon as the patient comes out of the MRI, you have no way anymore to communicate. So one needs, and we'll hear about that later, to develop cheaper and portable alternatives, which are called brain-computer interfaces, where you measure the electrical activity of the brain and do the same thing. Ask the patient to respond to command and then read the response. This is still an other technique where we try to communicate through movements of the pupil. Turns out to be that if you're a bit stressed or you do some mental calculation, your pupil will dilate, and we can again use that signal. We can just put the camera on the patient's eye, ask a question, and then say, well, if you want to say me no, do a mental calculation. Here we see no, pupil dilation. Then we ask again, if you want to say yes to this question, do 24 times 57. And then if the camera detects a dilation, and this is automatic signal detection, we can read that there's communication of a yes. This works very fine in lab conditions in healthy volunteers. It's already more challenging in locked-in syndrome patients, but some of them can do it quite well. It even worked in minimally conscious state patients, but it's more a proof of concept, because at the bedside, again, this is terribly challenging, and the signal-to-noise ratio is not very good. So we've said some of these patients after a severe brain injury, traumatic, anoxic, will evolve to coma. It will not last for more than a couple of weeks, this condition of coma. Some of them will awaken, showing reflex movements, eye opening, but nothing else, this persistent vegetative state or unresponsive wakefulness, where then again some will show visual pursuit, localization to pain or appropriate smiling or crying to familiar faces, minimally conscious state minus, and then the next step would be response to command, minimally conscious state plus. These two entities, MCS plus and minus, differ in terms of their brain function. You see much more left lateralized damage in patients who fail to show the awareness test, response to command, which really emphasizes another clinical problem where all these fancy tennis tests and brain-computer interface will still give us a problem, which is when the patient doesn't understand the question, when he's aphasic. It's not because you don't understand language that you're fully unconscious. You can still experience pain, you can appreciate music, some chocolate on your lips, and so on and so forth. So this, again, is a big problem for us at the bedside. And I think that these minimally conscious state minus patients with often left lateralized damage encompassing the language network illustrates that very well, when even these fancy fMRI tests or brain-computer interfaces will fail. This is why we've been investing a lot in tests that do not require any collaboration for the patient. And the easiest one can do is to just put her or him in an MRI scan and record resting brain activity. Because if you would be in MRI, you would be thinking, what am I doing here? What am I going to do tomorrow? And we can measure your spontaneous bold fluctuations, and the easiest for us to capture is the so-called default mode network, overlapping with the internal awareness network. You see it here in the front, in the back. And of course, in some patients, this can be very helpful. This is a classical example in a locked-in syndrome patient in the acute setting. You see the brainstem lesion here with the white arrow. From the outside, it's very hard to make sure that there's some consciousness, and the fMRI resting state data clearly show you these yellow blobs, and you can be all excited to see consciousness, and yet, of course, we need to be very careful. Sometimes the data are lying to us. We're seeing things we think represent consciousness, and it's noise coming from the scanner or some other artifact or some mathematical trick where we can get it wrong and get false positives. And so, of course, this is the challenge in this field where there's no gold standard. There's no way, like in a patient with a brain tumor, for example, you can do an autopsy, you can look under your microscope, there is a cancer cell or not. For consciousness, you have no way. Even when the patient dies, you can't look at consciousness under some microscope or whatever. So we will validate our paradigms in anesthesia, because there we can control the loss of awareness and again look at the breakdown of connectivity in this internal awareness default mode network when you compare wakefulness to mild sedation to loss of response to command, unconsciousness, and then the recovery. You see that the connectivity changes depending on consciousness. It's not the case for these so-called slave sensory systems. You see the visual network still shows activity even in anesthesia, and also the auditory network. As said, you need this widespread frontoparietal connectivity, and in disorders of consciousness after coma, you see again here this breakdown when you compare normal or locked-in patients with minimally conscious, with unconscious, vegetative, or comatose. This internal awareness network breaks down its connectivity, and the area that separates best unconscious vegetative from minimally conscious is this region here in the back of the brain, posterior cingulate cortex, and adjacent precuneus. This seems to be a critical hub in this widespread frontoparietal awareness network. Another interesting technique after resting state fMRI, where you don't have to ask anything from the patient, is this technique where Marcello Massimini will talk more about. It's perturbing the brain with TMS and then measuring the electrical echo with EEG. It's very difficult technically, but it's an elegant way to quantify the complexity of the system, we think, and this is also going with Tononi's integration information theory, that is needed for experience of consciousness. And then if you do this in sleep, in different states of anesthesia, and in patients with disorders of consciousness, you can draw some border. It turns out to be on this scale that captures this complexity. We call the PC, perturbational complexity index, that between 0 and 0.8, if you are above 0.3, all the measurements so far turned out to be in conditions of preserved consciousness. And of course, if this is true, this can be helpful clinically, again, to reduce the uncertainty regarding the patient's diagnosis. And that is needed because a number of studies have shown that we can get it wrong. We can get it wrong in about 3-4 times out of 10, where from the outside you think the patient is unconscious. And when you do appropriate assessments, even with clinical scales, the Coma recovery scale, if you compare the clinical diagnosis without a standardized, validated tool, you can miss in this series 35% of clinical misdiagnosis. And then if you have these high-tech tests, the functional neuroimaging, in this case the tennis fMRI test or the PET glucose uptake test, you see that, again, there's about a third of patients still showing surprise findings, meaning that even with the best bedside assessment, Coma recovery scale assessment, showing there's nothing, yet you have a surprise finding on the neuroimaging. And of course, this is important because studies have shown that when you have these minimal signs of consciousness, it means the patient can have some perception, and your clinical management should be different. And also, in this series, we showed that there is a prognostic information. All the exceptional cases of dissociation between clinical and high-tech testing subsequently, or most of them, the vast majority also show clinical signs of recovery, which are, of course, important. And the study also showed that despite its, well, I would say theoretical appeal, and it seems to be attractive to do this tennis test in each and every patient, it is terribly difficult to do. In about 4 out of 10 patients, you will simply not be able to even start the test because the patient moves too much. And in the remaining 60%, it's still going to be very challenging, and you will face a high number of false negative, meaning patient can be conscious and just fails to do the imagine playing tennis or imagine walking around your house test for many, many reasons. We will have a low sensitivity, whereas the positron emission tomography is, in our experience, doable in the vast majority, over 90% of the patients. Another technique, and I think the future is really to combine information from the different examinations, as we did in the last Lancet paper. Another interesting technique, I think, is diffusion tensor imaging. This is quantifying not the gray matter integrity, but the white matter. And as said, one neuron can't be conscious. We think you need an interaction, a functional connectivity, and that needs structural connectivity you can capture by MRI DTI measures. You see these blue tracts going down to the spinal cord, motor cortices. You see the red transcallosal tracts that connect both hemispheres, and then green front to back fibers. And we now know that if we quantify the damage in the white matter tracts, this is kind of the highways in your brain, this is helping us again to reduce the uncertainty regarding the prognosis. And I'm convinced that we will see more of this in the future, helping us to disentangle patients with bad and good prognosis already at the intensive care setting. After the challenge of getting the diagnosis right, the challenge of predicting the outcome, the prognosis, I think there is this challenge of treating these patients. And one question I think is important is whether we think these patients can perceive pain. It's a difficult question. We asked over 1,000 medical doctors a quite straightforward question. Do you think that patients in vegetative state can feel pain? You see results can't be more ambiguous. 56% said yes, even more so of the nurses. And, well, a kind of, it's interesting to see that the variable that correlated with their response was whether they were religious or not. And of course, we want to do better than that in our hospitals and get it more objective. We've developed this pain scale, nociception coma scale. Again, the challenge is to give sense to these responses. Do they really represent subjective experience of pain? And if so, should we give painkillers? Functional imaging can give us a more accurate reflection of what's happening in their brain, and you see that minimally conscious state patients, by definition, they can't tell us they feel any pain, but their brain scans do. You see activation of the whole pain network as seen in healthy controls, study done by Melanie Bowley. Here, anterior cingulate cortex activating to noxious stimulation in these patients, we think reflecting the fact that they experience some pain and should systematically receive analgesia. Finally, the therapeutic interventions, of course, better understanding can lead to better treatments. An older study where you see that there's a disconnection between the gray matter and the thalamus, and more specifically the interlaminar central thalamic nuclei, and Nico Schiff's team, who stimulated these deep structures, both thalami, which in some patients, this case post-traumatic minimally conscious state, could improve their level of awareness. And now also I think with non-invasive methods called transcranial direct current stimulation or others, we can try to increase the activity of the brain by putting electrodes not deep into the brain, with all the ethical considerations we will hear more about later by Joe Finns and others, but by simply putting electrodes on the skin and aiming to increase the activity here, which seems to work. You see in minimally conscious state patients, they would increase about 2 points on the Coma recovery scale, not so in the unresponsive wakefulness or vegetative patients. And now, of course, the challenge is to identify why some patients do and others fail to show improvement. And again, their functional imaging, we think, can help in identifying responders from non-responders. We'll hear later today and tomorrow about all the ethical challenges when trying to do this kind of research in patients who are, of course, vulnerable and should be protected, but also should not be overprotected, which gives the risk to keep them from having access to these new technologies. And we'll end with some challenges on quantifying again the meaning of well, the quality of life of these patients, which is challenging to capture. It's hard to quantify consciousness. It's hard to quantify pain. The same for a meaningful life. What is it like to be minimally conscious? I think it's a very important question, yet in the absence of a functional communication, it's hard to give a meaningful answer to this question. So what we did is ask that question to patients who are locked in, and maybe we can do this together for those who don't know the study. We use this scale going from -5, which is the worst period in your life. If you can try to imagine, David, the worst period in your life, paper rejected or divorce, and then +5, which is the best period in your life, paper accepted or a divorce. And then if you calibrate your own quality of life scale from -5 the worst to +5 the best, you can give an answer to the simple question, how were you the past 2 weeks? On this scale, what is your score? You don't have to tell me. But this is what we got from locked-in syndrome patients. So remember, you can't be more motor handicapped than this. These are chronic patients, can communicate through a small blink of the eye, and we see +3, +4. Majority of these patients telling us, yes, it is possible to have a meaningful life. Don't judge a book on its cover. Also, some of these patients, of course, score -5. We asked a question about euthanasia. This was done in France. There is no law on euthanasia. And we tried to identify which variables could explain why they were so unhappy. It seems that time is very important, and also the access to communication devices and social life. So, in conclusion, I hope I've given you some evidence that for you to be conscious, we need activity in a frontoparietal network. Nico is going to explain the mesocircuit model and the different ways we can try and modulate the activity. I briefly mentioned the deep brain stimulation of the thalami, the transcranial direct current stimulation, and I'm sure that Nico will tell you about some miracle cases showing recovery to zolpidem, which is a very interesting drug. And I would just like to end by how challenging it is to do this kind of research. We're talking about consciousness. It's not neutral. It's trying to capture the mind, spirit. It depends on our, as said, religious beliefs. At one time, we asked at meetings like this, scientists, medical doctors, do you think that mind and brain are two separate things? Well, many of us are still having this struggle to deal with dualism or monism. It is important, I think, for many reasons. Some would even claim that near-death experiences, I didn't mention it, but are taken for some as proof of life after death. I don't think that is true. I think we have scientific evidence of life after death. It is called organ donation. However, I think also that science and medicine has not taken this physiological reality of near-death experiences serious enough. So we're trying now to record many testimonies. We have over 200 now. It is good to know that most of them are positive. It's a very pleasant peacefulness experience for those patients who have this memory of a cardiac arrest, for example. Some would explain it simply by a lack of oxygen. It doesn't seem to be that simple. We compared the cause of the coma. You see 45 had a cardiac arrest, 30 had trauma, 65 had bleedings and other reasons for their coma. And it turns out that what they tell us afterwards is very comparable. Most of them feel peaceful. Many, over 80% have these out-of-body experiences, and we now know that there's in the brain this right temporal parietal region. If you stimulate it, you can produce these out-of-body experiences. So you see here a ranking of the most frequent dimensions of these phenomena, and trying to link them with etiology. And of course, the challenge is to explain how a very dysfunctional brain after coma can still have these very vivid experiences. I thank you for your attention, and I think we can take a couple of questions.